The emergence and proliferation, largely for the good, of new therapies for rare diseases and even ultra-rare diseases is challenging how we evaluate healthcare, challenging how we even look at matters of cost effectiveness. A few main factors have contributed to this actually proliferation of therapies for rare diseases. First of all is legislation. The Orphan Drug Act has been wildly successful in providing incentives for pharma bio companies to scope out, to research, and to generate new therapies for rare diseases. That has been augmented with very well-timed advances in the science. Our understanding of the human genome, our understanding about how to get to the point where we can actually start editing genes, advances in immunotherapy, so many great scientific advances. And the third thing actually is patient advocacy. Patient advocacy is becoming wiser, more sophisticated, and better able to negotiate the policymaking sphere. And so if you look at legislation, science, and patient advocacy, they're contributing to this generation of therapies. Now, we are now challenged to think a little bit differently about how we deal with these. For example, let's take a look at cost effectiveness. In fact, what we're learning from our patient advocates, our consumers, and society overall is that in general, society is more willing to pay more for therapies for people who are otherwise indisposed or don't have access to a workable therapy. If I have a patient or a family member who has one of these conditions and I know that their life is going to be short because there is no viable therapy out there, I want to have access to some sort of breakthrough therapy. Well, as it turns out, society gets that too, and society is saying we're more willing to pay. And so you've seen groups, in particular, NICE in the UK and a few others, including some organizations in the United States, start to say that costs per quality adjusted life year thresholds can be raised to allow for these new sorts of therapies under those conditions. Now that's very encouraging. We're still going to have to manage our budgets, and we're still going to be very concerned about the overall spending across rare diseases. Now keep this in mind. Until very recently, rare diseases were just that. They were rare, which means our patient populations were small. We did not have very effective therapies for many of these, and there are fewer rare diseases that have been scoped out at all. Well, what do we have now? We have identified more rare diseases, and we've been able to develop more therapies for these rare diseases. We recognize that these therapies are things for which we want to pay. These therapies also extend the lives of people, so they're racking up more healthcare costs. And so, whereas in the past, where rare disease was a small or maybe not even distinguished blip on a radar screen of a major payer, now there are more of them, and those blips are bigger. So we're going to have to make some tough decisions. But overall, I think that society has weighed in on its willingness to rethink cost effectiveness and other criteria for developing and providing access to these new therapies for rare diseases.